Recording in progress.
Good morning. Hope
Good
you
morning.
can hear me.
Yes,
Right. So can you see the slides?
yes.
Right. Okay. So we'll
Yes.
start the lecture. And this lecture is on, you can see the clinical anatomy revision. Revision in the sense this lecture will include the important clinical anatomy part, that is your upper limb, right? So you can remember I have done 16 hours of clinical anatomy lectures in particular terms, right? So I have summarized all these clinical anatomy part, and remember these are the things that you must remember when you are going for your clinicals as well, right? And some of these areas I will explain in details, and some of them I just highlight for you all to because I have done almost all everything earlier. I will just show you what are areas that you must remember, so you can go back and see, or you can revise your own the clinical anatomy area relevant to those parts, right? And remember, for the purpose of second MBBS, right? You don't want to by heart remember these things relevant to clinical anatomy, right? Because clinical anatomy books, and sometime in the tutorials, you might have learned these things, clinical procedures, right? For example, how to reduce shoulder dislocation, right? The surgical techniques, how to do appendicectomy, and details of surgical incisions, right? Then diagnostic methods and examination techniques. These things no need, right? So these things you will learn when you go for your clinicals after second M. But for the second MB, relevant to the clinical anatomy, don't try to by heart all these things. No need to study these things, right? But you must know these things. Surface marking of each and every region. Then principle of testing a muscle or muscle group, because there I will show you what are the important muscle and muscle groups. So those things you have to remember. That's relevant to you. Second MB, as well as when you're going for your finals, even you have to remember these things. Then principle of testing nerve injuries, you must know, because these things will come in your MCQs, essays, and then Viva, everywhere, right? Then palpable pulses, and where these pulses are palpable, right? Those are arterial pulses. Then superficial veins and their clinical uses, especially your upper limb superficial veins, lower limb superficial veins, and superficial veins in the head and neck region. Then lymphatic drainage, right? Lymphatic drainage is you must know, and you have to know the lymphatic groups, important lymphatic groups in the body, and special notes on regions, right? These are the first, whatever the things I have mentioned up to the lymphatic drainage is relevant to all the areas of the body. Then special notes on region, in different region you have some special maybe structures, organs. So you have to know certain clinical importances in those particular areas. For example, in the upper limb, breast is an important area or a structure, right? Having said that, so we'll start with the upper limb part. So these things I am not going to explain everything, but I will highlight what are the things that you have to remember. Regarding the clavicle, you must know it's palpable towards the length, so can feel its fractures. So I will go little faster, otherwise I will not be able to finish this thing by 2 hours time. So at any time you can raise your hand and ask questions, or you can post, right? So if you have anything you want to clarify, or if you think that I am so faster, right? So tell me, right? So at the shoulder, greater tubercle of the humerus, the most lateral bony prominence in normal anatomy. The acromion process forms the summit of the shoulder, and remember, acromion becomes the most lateral in shoulder dislocation. So in a patient who is coming with when you feel all these bony prominences, if someone having acromion become the most lateral, that patient you can diagnose is having shoulder dislocation. Then at the elbow region, you know, is the olecranon process and two epicondyles, medial and lateral, form a triangle. So supracondyle fracture lies above this triangle, so triangular relationship which remains. In dislocation of the elbow, the olecranon comes more or less in line with epicondyles, so it distorts the triangle. So this picture summarizes that. So there you can see the olecranon process, the medial epicondyle, the lateral epicondyle on the other side form the triangle, and the dislocation, the triangle relationship is distorted. But here, the supracondyle fracture, it is not distorted. Right. In the forearm, the ulna, you know, it's the posterior border, you can feel completely. So therefore, that is the site of convenient site for exposure of the ulna for surgical purposes. And any fracture, any diseases in the ulna, you can feel. The styloid processes, there are two styloid processes, radial and the ulnar styloid processes. Out of these, the radial styloid process fell distal to the ulnar styloid process. So in a case, if the radial styloid process felt proximal to the ulnar styloid process, suggests to a fracture distal end of the radius. At the wrist, out of the carpal bones, you should know that the scaphoid is felt within the anatomical snuff box, right? So therefore, there can be a characteristic tenderness at the base of your anatomical snuff box, right? That suggests to of scaphoid fracture. When come to the thorax, you must know the external angle of Lewis corresponds to the level of T4 and T5 disc, and the manubrium corresponds to the third and fourth thoracic vertebrae and ovalize the aortic arch. So out of these, this external angle is very important, because external angle also corresponds to the second rib. So counting of the ribs and the intercostal spaces started from there, because even in obese person you can very well feel the external angle, right? Then sternum corresponds to the fifth to eighth vertebrae and neatly ovalize the heart. You can see it in this picture, right? So this is the angle of Lewis for 5, and this is the place where the second rib is attached. So you start counting your ribs or intercostal spaces from there, because you know counting of intercostal spaces and ribs are important in surface marking of your lungs, heart, auscultatory areas, and in certain clinical situations, right? So clinically it is important to remember these levels. Right, T9 is corresponds to the xiphoid process, and L1, you know, that is the transpyloric plane passes or crosses this L1, and at this plane you should know what are the structures present in this transpyloric plane. It's because this will be asked in your essays, MCQs, or even in Viva questions. And also this is important to identify in cross-sectional anatomy, right? Sometimes the spots you might give in the at this level, right? So it passes through the pylorus, pancreatic neck, the DJ flexure, the fundus of the gallbladder, the tip of the ninth costal cartilage, and the hyla of the kidneys. It also corresponds to the level of termination of the spinal cord in adults. You know, in children, the spinal cord uh, lies at the level of L2 vertebrae, but in adult it ends at the L1. So there are a lot of things happen at this level. So remember these. What are the important things happen at L1 level? Right. The subcostal plane is the line joining the lowest point of the thoracic cage. That is the inferior margin of the 10th rib through the origin of the inferior mesenteric artery. Right. The intercostal plane is the imaginary plane that passes at the crest of the iliac crest. Right. So it also useful landmark in performing the lumbar puncture because it's demarcate the level of L4. So lumbar puncture is a procedure where we insert a needle into the uh, subarachnoid space in the spinal canal to take cerebrospinal fluid, right? So you have to do that below the level of the spinal cord, right? So that means below L1 level. So to identify that level, you can take these, you can surface mark the L4 vertebrae by palpating the iliac crest, and then you do this lumbar puncture between L3 and L4 vertebrae. Right. So these how you divide your anterior abdominal wall into 9 regions. There you can see there are 2 transverse plane. One is intertubercular plane. So intertubercular plane passes below the intercostal plane, right? That passes between anterior superior iliac spines. So it lies at the level of L5 vertebrae. The other plane is the transpyloric plane, passes at the L1. Then there are 2 vertical planes. Those are the 2 planes passes lower end at the mid-inguinal point. Upper is corresponds to the mid-clavicular line. Actually, this is the mid-clavicular line. So that divides your anterior abdominal wall into 9 regions, right? So you should know these. What are these 9 regions, right? So in the pelvis, you can feel uh, these bony prominences, right? The iliac crest, anterior superior iliac spine, posterior superior iliac spine, pubic tubercle, pubic symphysis, ischial tuberosity, and greater trochanter of the femur, right? So all these are very important bony landmarks because by using these, we can surface mark most of the structures in the pelvis and also in the abdomen, right? So the intercostal plane passes through the iliac crest and anterior superior iliac spine. uh, I have shown you is important in surface mark in the lower transverse plane, intertubercular plane, right? And pubic tubercle, pubic symphysis, all these are very important in surface marking your inguinal canal and taking the mid-inguinal point, and we'll see what are certain importances. So this is the anterior superior spine, how it is felt, and this is one importance I have shown to surface mark the McBurney's point, right? So you take a line between anterior spine and the umbilicus, then lateral 1/3 and medial 2/3 junction is the McBurney's point. This is only one example I have given, right? And in the behind, you can see there is the two dimples, right? So that denotes the posterior superior iliac spine, and you can see the posterior superior iliac spine that also corresponds to the center of the sacroiliac joint, the level of the sacral segment, the level of end of the dural canal of the spinal meninges, right? So there are very important things happen at this level, so you have to remember these things, right? So this just to show you the use of sacral tuberosity as a landmark for doing ultrasound examination in the gluteal region. For example, if you want to surface mark the sciatic nerve, and so this is very important landmark, right? Sacral conua, that is the uh, that is palpable immediately above the natal cleft, right, on either side of the lower extremity of the sacral hiatus, used for caudal anesthesia. So you can feel the sacral conua on either side of this upper part of the natal cleft, and in between you can see the sacral hiatus like this. So this place, through this sacral hiatus, you can insert a needle and inject anesthetic solution to anesthetize the perineum, right? So lower sacral nerves you can block, right? So it's important in doing certain clinical procedures in the perineal area, right? And these are the pressure points. These are important things because most of the areas there are body prominences where more pressure is exerted on the body depending on which side you lie. Now you can see this is a person who is lies supine. These are the bony
Good
prominences
evening.
and
I hope you are
areas,
doing
pressure
your
points that touches the uh, bed or the ground, right? Back of the head, shoulder, elbow, and if you lie on lateral side, the hip over the greater tuberous, greater trochanter, right? And these are called pressure points. And why it is important? These are the areas you have to examine on a patient who bedridden, that is lie for a longer period on bed to identify what are called decubitus ulcers or bed sores, right? So this is a patient who has developed a bed sore over the the ischial tuberosity, right? This is a bed sore, a very bad wound, right? So difficult to treat these things, right? Therefore, these are the areas we have to look for. This is a person who is lying supine like this for a longer period, right? Right, so these are some important surface marking. You have to know the axillary nerve, surface area over the deltoid muscle, posterior introsus nerve, flexor retinaculum, superficial palmar arch. Right, so I am not going to explain these things. So you have to know how to surface mark these areas. Right, remember these are very important to know. Right, then surface marking of the thorax. You have to know how to surface mark lungs and pleura, right? So it is very important. You can remember one, you can remember the other. We'll see the lungs, right? So apex of the lung lies about 2.5 centimeter above the medial 1/3 of the clavicle. Then their anterior borders come forward and they meet together at the level of sternal ankle. So we'll take the right side. So anterior border passes up to the level of 6 costal cartilage, and then it meets the trans or the inferior border, and the inferior border crosses the sixth rib at the mid-clavicular line, then 8th rib at mid-axillary line, and Posteriorly, it crosses the 10th rib, right, at the level of lateral border of erectus spinae muscle, right? So that is how then the posterior border meets the inferior border along the vertebral column, lateral part of the vertebral column. That is how you have to mention the surface marking of the lung. So if you know the lungs, then you should know the how to surface mark the pleura, right? So apex, the anterior border is similar, but the difference is the inferior border crosses the 8th rib at mid-clavicular line, then 10th rib at mid-axillary line, and posteriorly it crosses the 12th rib lateral at the lateral border of erectus spine muscles, and it passes below the 12th rib. It passes below the 12th rib to meet the posterior border, right? And other thing you have to know is uh, the difference between left and right. Right, on the left side, instead of crossing at the 6th costal cartilage, it crosses the 4th costal cartilage on the left side and goes downward to meet the inferior border at the 6th costal cartilage. This is the cardiac notch to allow the pericardial to accommodate the pericardium, right? So those that like that you should be able to surface mark the lungs and the pleura, right? So this is important point where the pleura passes below the 12th rib. That means it is in the abdominal posterior abdominal wall. So this part can be damaged during posterior abdominal wall surgeries, resulting pneumothorax, right? Resulting pneumothorax. So you should know the terms. What is pneumothorax? What is hemothorax? What is hemopneumothorax? Right. So pneumothorax is collection of air within the pleural cavity. Hemothorax is collection of blood within the pleural cavity, and hemopneumothorax means both air and blood. So when there is a fluid inside the pleural cavity, we call pleural effusion or hydrothorax, right? Right. So this is safe triangle, right? Where when there is any collection of air or either fluid, we have to insert a tube that is called intercostal tube into the pleural cavity. So we cannot insert intercostal tube all the places. You have to use safe triangle. So surface mark in the safe triangle you must know. So that triangle is surface mark by the anterior axillary line, then mid axillary line, and the inferior limit is the 6th rib, right? So the triangle formed by from these three lines. So within this you can insert intercostal tube, right? And to identify the 6th rib, for example, here you start counting ribs from external angle level downwards, right? Okay. Then commonly used intercostal space is the 4th intercostal space above the 5th rib. Right, and remember when you are inserting tube or a needle, you have to go over the upper border of a rib to prevent damage to the neurovascular bundle. Those are the anatomical principles that you have to remember. Okay. Surface marking of the heart. Right. So there are four bone the 4 points that you have to remember. Second left costal cartilage 12 millimeter from the external edge. Then third right costal cartilage 12 millimeter from the sternal edge, and sixth right costal cartilage 12 millimeter from the sternum, and fifth intercostal space 9 centimeter from the midline. So these are the important 4 points, and you join these 4 points to surface mark your pericardium or the heart. And here is the apex beat or the apex of the heart. So you have to remember, because the apex is
I didn't understand that.
Because apex is at the just medial to the midclavicular line, and this can deviation. It can deviate to the left side or laterally. That suggestive of enlarged heart. That is what is called cardiomegaly, right? That can happen in patients with hypertension, right? And there you can see these are the coronary valves. You have the surface marking of coronary valves. You can see it corresponds to the coronary sulcus. Right, right, okay. And so heart valves lie along a line of coronary sulcus, but the auscultated areas are placed at different places, right? Auscultatory areas mean these are the places where you keep your stethoscope to listen to the particular heart sounds, right? So you can see the sounds derived from the aortic valve, right? So aortic valvular sounds you heard on the right side, second intercostal space, just lateral to the sternum. Pulmonary heart sound, pulmonary valve closer you hear, and the second intercostal space, just lateral to the sternum, right? Then your tricuspid, you heard over the sternum at the level of sixth costal cartilage, sixth costal cartilage, and the mitral valve sounds you hear at the apex, right? So these are the places you have to keep your stethoscope and you're listening to the heart sounds, right? So surface marking of the liver. So liver, most of the liver is correspond to the right hypochondrium, but part of it extends to the epigastrium and even into the left hypochondrium. But remember, the liver is mainly a right hypochondrial organ, right? So its inferior border corresponds to the the line of the costal margin, and its upper border uh, is at the fifth intercostal space on each side, right? So normally the liver is not palpable, but when it's enlarged, it can be felt, right? And sometimes when if the liver is palpable, you have to look for the upper border as well. If the upper border is not at the fifth intercostal space, and if it has come down to a sixth or even seventh intercostal space, that suggests to a pushing of the liver downward rather than enlargement of the liver, right? So you have to know how to surface mark the liver. Then the surface marking of the spleen. So you know it is a left hypochondrial. It's placed at the left hypochondriac region. Its anterior border is behind the midclavicular line. Behind the midclavicular line, and the posterior border is about 5 centimeter from the posterior midline, and its long axis lie along the 10th rib, and the spleen lies between 9th and 11th rib. So that's how you surface mark the spleen. Right. The gallbladder, the fundus of the gallbladder corresponds to the transpyloric plane, where it crosses the lateral border of the rectus abdominis, or the linea semilunaris, right? That suggestive of the surface mark the or demarcate the fundus of the gallbladder, right? So when there is a gallbladder pathology, when there is an inflamed gallbladder, you feel the tenderness or pain at the tip of the 9th costal cartilage and on the right side, right? And enlarged uh, gallbladder also appears, or you can feel at the tip of the right 9th costal cartilage. Right, pancreas. So transpyloric plane define the level of the neck of the pancreas. Right, you can see the neck of the pancreas is crossed by the transpyloric plane at the midline, and from that point, right and inferiorly, the head is placed, and it lies in oblique plane and extending into the left hypochondrium towards the hilum of the spleen, the tail of the pancreas. Right, so that's the neck of the pancreas. The kidneys lies on either side of the vertebral column, the paravertebral gutters, and its hilum is corresponds to the transpyloric plane. But remember, the left one lies little lower. Sorry, right one is lie little lower than the left one because of the presence of liver. Right, so posteriorly the upper pole of the right kidney lies at the 11th intercostal space, you can see, whereas the left kidney, the upper pole lies at the level of the 11th rib. Right, so right one lies 2.5 lower than the left side. Right, appendix, I told you how the surface mark is. At the surface mark, the McBurney's point. Remember, at the McBurney's point, it lies the base of the appendix. You know, the tip of the appendix is variable. So it can vary the level of the tip of the appendix. It may be even retrocecal, or retroileal, or pelvic. Those are the common places. The most common place is retrocecal, but base you can surface mark by the McBurney's point. Right. So in the lower limb, you should know how to surface mark the femoral artery. That can be surface marked by feeling the midinguinal point. So midinguinal point can be surface marked by feeling the anterior superior iliac spine and the symphysis pubis. So midway between anterior superior iliac spine and the symphysis pubis is the midinguinal point. So your femoral artery is at the origin is at the midinguinal point, and the whole femoral artery you can surface mark by taking the upper two-thirds of a line joining the midinguinal point to the adductor tubercle with the hip somewhat flexed and externally rotated. Right, so it's upper two-thirds of this line, it corresponds to the femoral artery in the thigh. So immediately medial to the artery is the femoral vein, and a finger breadth lateral to the artery is the femoral nerve. So that's how you surface mark these three structures. Right, sciatic nerve you can surface mark. It is in the gluteal region. So it's enter into the gluteal region from the pelvis, midway between the posterior superior iliac spine and the ischial tuberosity, and it exits the gluteal region midway between greater trochanter and the ischial tuberosity. So it has a somewhat curved course between these 2 points, right? So that's how you surface mark your sciatic nerve. Just like your deltoid, though, the shoulder area, using the deltoid for IM injection, your gluteal region also used for intramuscular injection. And remember, these injections are given to gluteus medius, not to the gluteus maximus. And for this purpose, when you are injecting, you must save the sciatic nerve. For that purpose, you have to define the safe area for IM injection. So it is the area which lies under the outstretched hand when the thumb and thenar eminence are placed along the iliac crest, with the tip of the thumb touching the anterior superior iliac spine. And when you take that, this is the safe area. And so when it comes to a living person, it is this area, right? So you give injection not to the gluteus maximus but to the gluteus medius. Right. So femoral and inguinal hernia, you know, the hernia coming through the inguinal canal we call it inguinal hernia, and hernia coming through the femoral canal is called femoral hernia. So they are neck of these two herniae you can surface mark by using the pubic tubercle. Right. So femoral hernia lies below and medial to the pubic tubercle, and neck of the inguinal hernia lies above and medial to the pubic tubercle, and femoral hernia neck lies below and lateral to the pubic tubercle. Right. In the head and neck region, you should know what are the midline structures that you can feel. Right. So, you can see the hyoid bone, then you can feel the thyroid cartilage, then the cricoid cartilage, then at C6 level, you can feel the cricoid cartilage. Then you get the thyroid isthmus below the cricoid cartilage, which overlies second to fourth tracheal ring, and then the supraesternal notch. Right. So Terrian, you should know how to surface mark. It lies 4 centimeter above the midpoint of the zygomatic arch. Then internal jugular vein, a line from the lobule of the ear to the medial end of the clavicle. Cannulation is done between two heads of the sternocleidomastoid muscle because the vein exactly passes between these two muscles. The facial nerve, the origin or the exit point of the facial nerve, you can surface mark at the inverted V between the bony part of the external auditory meatus and the mastoid process. Right, so those are surface marking, then the testing of muscle. These are the things that we have to know. So I am not going to describe each and everything, but I will highlight what are the individual muscles that you should know to surface to test. The deltoid, pectoralis major, latissimus dorsi, biceps and tricep muscles in the upper limb. The basic principle is doing the action against resistance. Right. That is the basic principle of testing a muscle. So as you know, the deltoid is the abductor muscle. So what you have to do is you have to abduct the shoulder against resistance. Then you can feel the contracting of these muscles. Like that, you can test all the other muscles also. Then biceps, if you want to test, you have to do flexion of the elbow against resistance like that. Right. Against resistance. Right, like that, you should know the action of the muscle, then apply the resistance and do the function. So remember how to test these muscles. Right. Then in the upper limb, again you have to know how to test the flexor pollicis longus, extensor pollicis longus, flexor digitorum superficialis, flexor digitorum profundus. So flexor pollicis longus, you know the function of flexion of the distal phalanx of the thumb. Extensor pollicis longus is the one that extends the distal phalanx of the uh, thumb. Flexor digitorum superficialis is the one that flexes the distal interphalangeal joint of the fingers. The flexor digitorum profundus, flexor digitorum profundus, you can test by asking patient to flex the distal interphalangeal joint of fingers. Then to test the flexor digitorum superficialis, you have to cancel the action of flexor digitorum profundus by extending all the fingers and ask to move the remaining finger like that, right? So now the flexion of your small finger is done only by the flexor digitorum superficialis. Like that, you can test all the other fingers as well, right? Then dorsal introsei, palm introsei, adductor pollicis, abductor pollicis, right? All these we have to remember how to surface the test all individual muscles. Gluteus maximus is the one that extend your hip. Gluteus minimus and medius, you know, by doing the Trendelenburg test, right? Then hip flexors, individual flex muscles of this hip you cannot test, but you can test the hip flexors, adductors, extensors, and abductors as a group of muscles. So what you have to do, if you want to test the flexor muscle, you flex the hip against resistance, right? Then adductors, you adduct the hip against resistance like that. The knee flexors and knee extensors similar. You flex the knee against resistance, you extend the knee against resistance, then you can test the knee extensors and knee flexors. Soleus and gastrocnemius, you know that you can test by asking dorsiflexion of the plantar flexion of the ankle against resistance, right? Another thing is, one simple method is testing the function of soleus and gastrocnemius. We can ask the person to stand on tip of toes, tip of the toes, right? So if the soleus and gastrocnemius are damaged or paralyzed, they will not be able to stand on tip of toes, right? Then flexors and extensor hallucis longus, then again same thing. So the flexor hallucis and the extensor hallucis you can test by testing the interphalangeal joint of the big toe flexion and extension, right? Only thing you have to know is what is the function of the muscle or the group of muscle. You have to do the function against resistance, right? Then sternocleidomastoid, trapezius, masseter, and temporalis, pterygoids, orbicularis, oculi. These muscle testing also you must know. You know sternomastoid muscle, for example, turn the face to the opposite side. So if you want to test the right side, what you have to do, you keep your hand on the left side and ask patient to turn the head towards the left side. So that means now the muscle of the right side is acting. You can see if you do this, the right side sternomastoid muscle is contracting, right? Like that, all the muscles, the trapezius, struck the shoulder, masseter, is you can see those are elevators of the mandible. So ask patient to cleanse the teeth tightly, then you can feel those two muscles. Pterygoids opens the mouth, orbicularis oculi, close the eyes tightly. So you do all these actions, then you can test those muscles. Right. Then come to nerve injuries. Right. So any questions so far? Anything? I think it's a bit fast, but can't help. So, right. Any questions? Okay. So these are the common sites where nerves are injured in the upper limb, axilla. Nerves are thoracodorsal, long thoracic nerve, and intercostal brachial nerve, especially in axillary surgeries. Right, thoracodorsal nerve, that is nerve that supply the latissimus dorsi. Long thoracic nerve, you know, it supply the serratus anterior. Intercostal brachial nerve supply the sensory to the base of the or the floor of the axilla and the medial upper medial side of the arm, right? So how to test thoracodorsal nerve? You test the function of latissimus dorsi muscle. So paralysis of lower thoracic nerve causes wing scapulae, intercostobrachial nerve damage plus subsensation of the area supply. Then axillary nerve, radial nerve, and ulnar nerve is damaged in the arm. You know, axillary nerve damage at the the surgical neck, radial nerve at the spiral blue, and the ulnar nerve at the behind the medial epicondyle. Right. And at the elbow and the forearm level, median nerve, ulnar nerve, posterior introsus nerve, and anterior introsus nerve can be damaged. At the wrist, median nerve and ulnar nerve can get injured. So these are the sites where you get your axillary nerve and radial nerve and the ulnar nerve injury. Right. So axillary nerve may be injured in fracture of the surgical neck or humerus and in dislocation of the shoulder. So these are the deformities or dysfunction you see. Weakness of the shoulder abduction due to paralysis of deltoid and wasting of the deltoid. So you see the flattening of the bulge of the deltoid. Right. Then a small patch of anesthesia over the deltoid, a handbreadth below the tip of the shoulder. Right. Radial nerve injury you should be able to localize because it can damage at the axilla, then spiral groove, then it can damage the deep branch at the level of elbow, then it can damage the posterior introsus nerve. So at different sites it gives different clinical scenarios. So you should be able to localize. For example, damage in the axilla loses all the functions. Sensory loss, wrist drop, loss of elbow extension, weak supination, and loss of extension of metacarpophalangeal joint. These are the functional loss when there is a complete injury to the radial nerve at the axilla. Right. You can see there is only weak supination because there is a bicep is intact. Right. So damage at the spiral groove, weak elbow extension because long head of the tricep is supplied in the axilla, right, and the medial head as well. So there is a weak elbow extension and all the other function which is mentioned above is lost. Then damage to the deep branch, elbow extension is intact because it already supplied the tricep muscle, and no sensory loss because superficial branch supply the sensory, and no wrist drop because extensor carp radialis longus is intact. Weak supination and metacarpophalangeal joint extensions are lost. Right. Then damage to the posterior introsus nerve results only loss of metacarpophalangeal joint extension. No wrist drop, no sensory loss, intact elbow extension, and normal supination will be there. So you should be able to mention or state the different deformities and dysfunction when the radial nerve is damaged at different levels, and you should know what is the anatomical basis for these different clinical symptoms and signs. Right. So disability produced by the radial nerve injury is wrist drop, and it results inability to grip firmly. You will not be able to hold an object firmly when without proper wrist extension. So you can test it yourself. Take a pen and hold like this and flex your wrist. You can see you will not be able to properly firmly grip it. Right. So wrist extension is important or the extensor function is important in having a good grip. Right. Sensory loss in radial nerve palsy is limited to a small area over the dorsum of the hand, in the web between thumb and index finger due to overlapping of the nerve. Right. Otherwise, the radial nerve gives lower posterior cutaneous nerve of the arm, then the posterior cutaneous nerve of the forearm, and the superficial radial nerve. Three cutaneous nerves, but sensory loss only a small area. Ulnar nerve injury, what are the deformities? You see the clawing of medial two fingers, that is called ulnar claw hand, is this, right? Remember, there is a complete claw hand like this in Klumpke's palsy and is different from ulnar claw hand. The radial deviation of the wrist during flexion, that is due to flexor carpi ulnaris paralysis. The disabilities, sensory loss over the ulnar 1.5 fingers and hand, loss extension of interphalangeal joint of medial two fingers, loss abduction and adduction of fingers, loss adduction of the thumb. All these you no need to by heart these things, because you know the ulnar nerve and its function. What are the muscles supplied by the ulnar nerve? What are the area that supplied by the ulnar nerve, the sensory supply area? So then you can work out if ulnar nerve damage, what can happen. You can work out. For example, it supplies the adductor pollicis. So when the adductor pollicis is paralyzed, the loss of adduction of the thumb, like that you can work out everything. For any nerve injury, you should not by heart the symptoms and signs or disabilities and deformities. You should be able to work out. Only thing you have to know, what are the functions of these nerves. Right, so the clawing is less intense when the nerve damage at the wrist. So that is called ulnar paradox. That explanation is, or the anatomical basis is, due to the paralysis of medial half of flexor digitorum profundus. Right, so this is ulnar claw. Right, testing for weakness of interossei. You know how to test this. So this is the testing of the palm interossei. Right, holding a finger with the card between two fingers. That is the function of adduction you test. Right, so this is the testing of adductor pollicis, the Fromet sign. You can see side of the lesion. So the he cannot adduct the thumb. Instead, he does flexion of the distal phalanx and holding the card. Right, this is Fromet sign, testing of adductor pollicis. This thing I have explained, so you can just refresh your knowledge. The median nerve can be injured again at two places, at supracondylar fracture and at the wrist, because you know median nerve is a superficial structure at the wrist before it enters into the carpal tunnel. So even the superficial cut at the wrist can injure the median nerve. The other place is the median nerve can compress within the carpal tunnel and causes carpal tunnel syndrome. Right. So this is the deformity, what is called ape hand, where you can see thumb is straight because paralysis of opponent pollicis, right? And index fingers extend more than normal, right? Because paralysis of lumbricals prevent the flexion at the metacarpophalangeal joint. And other thing, the the flexors also paralyzed, and these two, you know, the flexor digitorum profundus is intact, so therefore these two fingers can flex, but here these two fingers cannot flex due to paralysis of flexor digitorum profundus as well as flexor digitorum superficialis. Right, so they kept little extended. Right, so best clinical test for this to check the function of the abductor pollicis brevis, that is pen touch test. Right, so this test the abductor pollicis brevis, which is supplied by the median nerve. Right, So median nerve injury division at the elbow results in serious muscle impairment. Pronation of the forearm is lost due to both paralysis of both pronator teres and pronator quadratus. And wrist flexion is weak and accompanied by ulnar deviation, right, due to the action of uh, extensive carping ulnaris. Right, anterior introosseous nerve palsy, it results damage to the flexor pollicis longus muscle and loss flexion at the distal the interphalangeal joint of the thumb. So this is a person with paralysis. He cannot flex the interphalangeal joint of the thumb. So he cannot do this. Instead, he does like this. Right. This is a diagnosis of anterior introosseous nerve palsy. Right. Carpal tunnel syndrome. The nerve can compress within the carpal tunnel. Is a paresthesia, numbness, and motor weakness in its distribution occur. And remember, there is no sensory impairment in the palm because the palmar cutaneous nerve passes superficial to the flexor retinaculum. And symptoms are relieved by dividing the retinaculum longitudinally. That is called carpal tunnel decompression. Erb's palsy. This is a brachial plexus injury. You can see this is how it can occur when there is a hole like this, stretching of the root of the upper roots of the brachial plexus. So this is the deformity you get, what is called Porter's tip deformity. Remember, even though the wrist is flexed like this is a normal relaxed position of your wrist. There is nothing happened to the wrist flexors or extensors, right? Okay, so Erb's palsy. These are the things can happen. It's called paralysis of deltoid and short muscles of the shoulder and of brachialis and biceps muscle. So what happened? Paralysis of deltoid results adduction of the shoulder. Abduction is lost. And the resultant short muscle paralysis results loss of lateral rotation. So the shoulder is medially rotated. And these extensors, so flexion of at the elbow and the supination become weak. So therefore, elbow is extended and pronated. So arm hangs limply by the side with the forearm pronated and palm facing backwards, like Porter's hinting a tip like this. So you should be able to explain why these deformities are. Right, in Klumpke's palsy, this is the incident hyper abduction or stretching of the lower root T1, and results is this complete claw hand. Right, okay, in upward traction of the arm and direct invasion of pulmonary carcinoma or by cervical rib, and may associate with Horner syndrome in the case of pulmonary carcinoma involved in the T1 root. The intrinsic muscles of the hand is affected because those muscles are supplied by T1. So all the small muscle of the hand is paralyzed, including your thenar and hypothenar and lumbricals and introosseae. Right, so hand assume a clawed appearance, become claw hand, complete claw hand, and know to differentiate it from ulnar claw hand. And these are the dermatomes. You have to know the dermatomes of the upper limb as well as lower limb and head and neck regions. Right, because especially the upper limb, lower limb and head and neck region, because your sports usually we give from the head and neck, upper limb and lower limb. Right. So I'm not going to explain. You can see these things from any textbook, right? Harold Ellis, you can see those things. The nerve injuries of the lower limb. There are mainly 4 nerves that can injure sciatic nerve. So complete damage to the sciatic nerve. So again, you can work out. You know the sciatic nerve supply the posterior compartment of the thigh and whole muscles of the leg and foot. So when all these muscles paralyzed, what happened? You should be able to work out, right? Don't by heart. So I will just feed these things. Mark wasting of the muscle below the knee. Weak flexion of the knee, sartorius and gracilis are intact. Weak extension of the hip. The gluteus maximus is intact. And the foot assume the position of foot drop. Right? Foot drop is due to the effect of gravity. Then sensory, loss of sensation below knee except medial side of the leg and foot, which is supplied by long saphenous or the saphenous nerve. Then femoral nerve injury results paralysis of anterior compartment of the thigh. So wasting of quadriceps, loss of extension of the knee and weak flexion of the hip due to paralysis of rectus femoris and intact as major. Sensory manifestation is loss of sensation over the area supply, that is anterior medial aspect of the thigh and medial side of the leg and foot, the saphenous nerve. Obturator nerve, you know, it's the nerve of the adductor compartment, so there will be loss of adduction at the thigh. And there will be only a small area of sensory loss on the medial side of the thigh. Common peroneal nerve injury. This is the most common nerve to injure in the lower limb because you know that is the only palpable nerve in the lower limb where it winds around the neck of the fibula. So it results foot drop, weak inversion, loss aversion, sensory loss at dorsum of the foot. So you should be able to explain why this happened. You know the function of the common peroneal nerve. It has 2 main branches, deep and superficial peroneal nerve, and superficial peroneal nerve supply the peroneal compartment and deep branch supply the anterior compartment. Right. So main deformity is the foot drop. Right. Tibial nerve injury, on the other hand, it's the nerve that supply all the muscles of the sole and the back of your leg. Results in following clinical features: all the muscle in the back of the leg and the sole of the foot paralyzed. So opposing muscle dorsiflex the foot at the ankle, right? Because extensors and the peroneal groups are intact, and therefore the foot is everted. So it is called calcaneovalgus deformity. Sensory loss over the lateral side of the leg and foot. So there will be what are called trophic ulcers in the sole, right? Trophic ulcers, that is due to loss of sensation. You can get repeated injuries and you can get ulcers in the sole, right? And in addition to common peroneal nerve injury, remember when the deep peroneal nerve injured, you get foot drop, right? So dermatome of the lower limb, again you have to remember, and remember at least this thing. If you can't remember everything, 541 and 145. Here you can see L5 supply the first digit for the big toe, L5. So 541 and 145. S1 supply the fifth toe, right? So at least remember that. Cranial nerves, olfactory nerve can injure in fracture anterior cranial fossa that results anosmia, and optic nerve injury results blindness. Oculomotor nerve injury, that is the most common nerve to compressed in increase intracranial pressure in head injuries. So therefore you can get dilated pupils and absent direct light reflex on the affected site. And also, you know, the diplopia due to paralysis of all the muscles, all the extraocular muscles except your lateral rectus and superior oblique muscles. Remember, I have not mentioned there will be complete ptosis as well, right? Due to paralysis of levator palpebrae superioris, there will be complete ptosis. Trochlear nerve injury, paralysis of superior oblique muscle, diplopia when looks medial and downward. The action is climb down in staircase. Trigeminal nerve, it has three divisions: ophthalmic and maxillary or sensory nerve. So damage to this nerve results sensory loss of the area supplied. And mandibular nerve is a mixed nerve, and damage to mandibular nerve results in paralysis of muscles of mastication. So there will be deviation of mouth to the affected side when mouth is open. This is due to the action of lateral pterygoid muscle. Abduction nerve paralysis leads to deviation of the affected eye to the lateral side, and there will be diplopia when looking at the affected side. Facial nerve, again one of the nerve that commonly encountered uh, in clinical practice. So it has several functions: motor to the facial expression, and also it supplies the stapedius muscle, and it secrete motor to the lacrimal and submandibular and sublingual glands, and it carries taste sensation from anterior two-thirds of the tongue. Right? This is again like your radial nerve injury. The nerve can be injured at different levels and results different clinical scenarios. Right. So can injure at cerebropontine angle at its exit from the brainstem, at internal acoustic meatus as it enter into the internal acoustic meatus, within the middle ear, within the stylomastoid foramen, within the parotid gland, or individual branches in the face due to certain especially during certain surgical procedures. So these, and in addition to that, I have not mentioned, it can damage at nuclear level, what is called upper motor neuron lesions, right? So facial nerve in and outs, you must know everything for the purpose of your neuroanatomy as well as gross anatomy, head and neck, right? So this can be questioned at any place: MCQs, SBRs, essays, YY, right? So this must know how to localize. So upper motor neuron lesion at the nuclear level affect opposite side lower part of the face. The reason, the anatomical basis you must have learned in your neuroanatomy, right? So remember that injury at the internal acoustic meatus result loss of all the function, facial muscles, and loss of hearing, results hyperacusia due to paralysis of the stapedius, and loss of salivation and loss of taste. All the functions are affected, right? All the functions are lost. When the nerve damage in the middle ear, lacrimal secretion is intact and lost the other function, because you know at the genu of the facial nerve it gives it uh, greater petrosal nerve which carries the secretomotor to the lacrimal gland foramen. So lacrimation is intact and stapedius muscle is already supplied, so no hyperacusia, but all the other functions are lost. Secretomotor to the saliva, so salivation lost, and facial expression also lost. Then the nerve can damage at the parotid gland, then only the facial muscles are affected. Because you know at the stylomastoid foramen it gives its coda tympani branch which carries the secretomotor to the salivary glands, right? And then individual branch, you know, it can damage, for example, the marginal mandibular branch can damage during submandibular gland surgeries, right? So you know what is happening when that branch is damaged, the mouth deviates to the unaffected side, right? Vestibulocochlear nerve leads to deafness and imbalance or vertigo. Glossopharyngeal nerve injury results loss of taste sensation at posterior one-third of the tongue and loss of secretion from parotid gland because it is supplied by the glossopharyngeal nerve. Vagus nerve, you know, it is a parasympathetic to thorax and abdomen. So the parasympathetic effect, the loss affect your thoracic and the abdominal organ. And there are two important branches of the vagus nerve, recurrent laryngeal nerve and external laryngeal nerve. These two nerves can injure as individual branches. You know, damage to external laryngeal nerve results loss of high pitch voice, inability to produce high pitch sounds, right, due to paralysis of cricothyroid muscle. Then recurrent laryngeal nerve injury, you must know that in and out again. Unilateral paralysis results hoarseness, bilateral paralysis results loss of phonation and inability to breathe, right? Then because the recurrent laryngeal nerve supply all the intrinsic muscles of the larynx except the cricothyroid muscle. The accessory nerve, the cervical part paralysis results loss the paralysis of trapezius and sternomastoid muscle. So that results, I told you how to test the trapezius and sternomastoid muscle, right? So lost shrugging on the affected side and inability to turn the face to the opposite side. Hypoglossal nerve injury in the neck result deviation of the tongue to the affected side due to the action of unaffected genioglossus muscle. Upper motor neuron lesion preserve the action of genioglossus muscle, so you will not be able to see deviation of the tongue. Right, so these are the dermatome of the head and neck. So most of the head and neck area supplied by your trigeminal nerve, you can see, and it is contributed by C2, C3 and C1. And remember, the C1 does not have a cutaneous sensation. It does not carry sensory from skin, C1. But remember, it has sensory fibers from the meninges, right? It has sensory fibers from meninges. Right, so you have to know what are the areas supplied by C2, C3 and C4, and these areas supplied by is ophthalmic, maxillary and the mandibular branches, right? And you have to know the individual nerves as well. In this area it is supplied by your great occipital nerve, right? Sorry, great auricular nerve, and behind the lesser occipital, and this area is great occipital nerve. Right, so these are the palpable pulses in the body. Radial, that is the most common pulse to feel because that is the readily palpable pulse and easily accessible at the wrist, right? Radial pulse, you should know where to feel this, right? So I will tell the radial pulse is felt between your flexor carpi radialis and brachioradialis tendons, right? Ulnar pulse again, flexor carpi ulnaris and flexor carpi, flexor digitorum superficialis tendons. Like that, you should know where to feel the brachial artery, femoral artery, popliteal, dorsalis pedis, posterior tibial, and the carotid pulse. You feel the common carotid pulse at the and over the anterior tubercle of the C6 cervical vertebrae. Then facial artery and temporal arterial pulses. So you should know where to feel all these pulses, right? And out of these, the most difficult pulse to feel is the popliteal pulse because That is the deepest structure in the popliteal fossa. Right. Therefore, this is the most difficult pulse to feel in the body. Right. Veins, superficial veins. There are two veins in the upper limb. That is the cephalic and the basilic vein. Right. So these are the again most common vein to use for IV access, especially the cephalic vein. Right. You can insert IV cannula, and these two veins are joined together at the in the cubital fossa by the median cubital vein, and this is the most common vein used to take blood for investigations because it's readily accessible even in obese people. Even though you can't see it, you can feel that, right? And there you have to know the important anatomy there. The bicipital aponeurosis deep to the median cubital vein protect the underlying brachial artery by accidental punctures. Right. So this is what I have mentioned. And the lower limb veins, not this is very important to know the structural arrangement, because there are two superficial system, long saphenous vein and the small saphenous system, and deep veins, and these are connected by perforating veins or communicating veins. All the other parts of the body, you get these communicating veins, but it's well apparent in the lower limb, right? And you remember they have all these veins have unidirectional valves. Valves are directed towards the heart, superficial to deep veins. Right, so these are anatomy you have to know. I am not going to explain. Great saphenous and the long saphenous vein. And regarding the long saphenous vein, you have to know it has tributaries at the groin, superficial epigastric, superficial circumflex iliac, and superficial external pudendal. And all these three should be ligated during surgery. Right. And the superficial epigastric communicate with the lateral thoracic tributary of the axillary vein via the thoracoepigastric vein. And these veins present as superficial veins of the abdomen, and this vein is dilated when there is an obstruction to the inferior vena cava, right? Because when there is obstruction to the vena cava, the venous blood of the inferior vena cava coming from lower limb shunts to the axillary vein and to the superior vena cava via this thoracoepigastric vein. And this is the constant position of the great saphenous vein where you can readily access in an emergency for what is called venous cut down to access for venous system for giving some blood or any medication. Right. Head and neck region, the internal jugular vein, I have mentioned that lies in the carotid sheath and no valves, and right one is used for monitoring the jugular venous pressure and insert central venous catheterization because it directly continues with the superior vena cava, thus with the right atrium. Right. Right. So these things not that important. That we yeah. So I have mentioned this thing again also earlier. Right, superficial veins of the neck. Out of these, you know, the external jugular vein is the most superficial vein, which is important in IV access, right? Because when the upper limb or the lower limb superficial veins are not available, you can insert cannula into the external jugular vein in the neck. Another important thing, this vein pierces the deep fascia of the posterior triangle, and therefore when the vein is cut at the posterior triangle, there can be fatal air embolism. On the other hand, the anterior jugular vein form a important landmark for the midline of the neck, because there are two anterior jugular veins passes on either side of the midline of the neck, right, deep to the uh, sorry, superficial to the deep fascia. So that's important identification of midline in case of thyroid surgeries. Right. This is the esophagus venous system. So I am not going to explain the anatomy of the esophagus venous system. The important thing is this is a venous system that shunt blood from inferior vena cava to the superior vena cava. So when there is a superior vena cava obstruction or inferior vena cava obstruction, blood can shunt from either superior vena cava to the inferior vena cava or inferior vena cava to the superior vena cava, depending on which side is obstructed. And remember, the importance is this venous system does not have valves. No valves in esophagus system. And this system also connect with the internal vertebral venous plexus, so they can connect with the cerebral veins as well, right? Therefore this channel also facilitate any malignant cells transmission or shunting of malignant cells from affected site into without passing the through the lungs. Lymphatics of the head and neck. There are two groups, deep and superficial. And superficial group arranged as vertical and longitudinal groups. So important superficial groups are submental, submandibular, and parotid and retroauricular or occipital nodes. And there are other, even though they place deep, we call them peripheral node along the trachea, retrotracheal and retropharyngeal nodes and all these, and your deep nodes or the terminal nodes lie along the internal jugular vein. So ultimately all these peripheral nodes drain to these deep nodes, right? Right. So there are two constant deep nodes. One is at the internal jugular vein and the common facial vein, that is called jugular digastric or tonsillar node. That is in relation to the posterior belly of digastric, because this node drains the tonsils. And the other node lie where the internal jugular vein crosses by the omohyoid muscle. So that is called jugular omohyoid node, and this node drains the tongue. So when there is a malignancy of the tongue, the jugular omohyoid node will enlarge. So what is block dissection of the neck? And that is performed for carcinoma involving the cervical nodes. Block dissection means you remove the lymph nodes and surrounding structures as a block, in one block together. So these are the structures that remove with the lymph nodes and lymphatics. The sternomastoid muscle, omohyoid and digastric muscle, the external and internal jugular veins, the submandibular gland and the lower pole of the parotid, the accessory nerve. But remember, when there is a bilateral block dissection, you have to preserve one internal jugular vein. You cannot remove both internal jugular vein. Right. So you have to preserve anyway in any block dissection the carotid arteries, vagus trunk, cervical sympathetic chain, lingual, hypoglossal and phrenic nerve you must remove. In case of bilateral block dissection, one internal jugular vein is preserved. So what is Trozius node, Trozius sign and Virchow's node? So Virchow's node is the enlarged left supraclavicular node. So that is the important node which can enlarge in malignancy of your abdomen as well as in pelvis. Right. And presence of Virchow's node is known as Trozius sign. So axillary nodes, there are 20 to 13 number, you know, it's arranged as 5 groups. So no need explanation of these 5 groups. So these are the 5 groups, and main drain area is the breast. So that is the important area that drain to this axillary node. In addition to that, it drains the whole upper limb and the trunk above the level of umbilicus. Right. So when there is any malignancy or infection in the breast or upper limb or the upper part of the trunk, these axillary nodes can enlarge and they are not normally palpable. Right. Inguinal nodes, on the other hand, it's again there are superficial and deep group. Superficial group, that's arranged in the horizontal group and the vertical group. Horizontal group along the inguinal ligament and the vertical group along the great saphenous vein. Right, and it drains the lower trunk back below the level of umbilicus, the buttock, then the perineum, scrotum, and penis, lower vagina and vulva, and the anus below its mucocutaneous junction, and from the fundus of the uterus. So this area, remember, these special areas also drain to the inguinal nodes, right? So longitudinal chain receive bulk of the superficial lymph drainage of the lower limb. Ultimately, all these reach the deep inguinal nodes, which lie within the. There are importantly 3 nodes within the femoral triangle, right? And the gland spine is directly drained into deep nodes without passing through the superficial nodes. That is other important thing. Right. Right. So differential diagnosis, lump in the femoral triangle, and similarly you should know the differential diagnosis of popliteal fossa, the triangles of the neck, right, and axilla. This is, I have given only one example from the femoral triangle. So if you know the type of tissue there, for your level, you can mention what is the lump, right? Skin and soft tissues, lipoma, sebaceous cyst, and sarcomas, artery aneurysm and femoral artery, and vein, varix of the great saphenous vein, nerve, that is nerve tumors, neuromas, femoral canal, femoral hernia you can get, and Schwartz sheath is there, so Schwartz abscess, and lymph nodes, any of the causal lymphadenopathy, right? Lymph nodes can enlarge, right? So special consideration of the upper limb, the breast, so and dislocation of the shoulder, elbow dislocation, supracondylar fracture. The important thing I have highlighted earlier is scaphoid fracture, then spaces of the hand. You have to know these things, right? And they are hand infections. So breast, I will just highlight important areas. Abscess in the breast should drain via radial incision. This is a radial. This is radial incision. This is curve or circumareolar incision. So why radial incision? This is to prevent cutting of the glandular tissue, right? Because glandular tissues arranged in radial fashion. So this direction cutting is important deep to the skin, right? But it's better to cut the skin in curvilinear or circumferential incision, which is cosmetically better. But internally structure you have to cut in radial fashion to prevent damage to the ducts of the glandular tissue. Dimpling of the skin is a sign of a carcinoma. So over a carcinoma, breast result from malignancy. That is due to infiltration of Cooper's ligament and contraction. Here you can see the dimpling in this area. Right. Then recent onset retraction of the nipple suggestive of involvement of lactiferous ducts in the fibrous contraction of the breast carcinoma. Right. So here you can see nipple inversion due to involvement of the ducts by the carcinoma. And this is the body orange appearance. There you can see the appearance of the skin of the breast is like a like orange, right? So appearance, this is due to the lymphedema of the skin. So you can see edema of the skin and hair follicles you can see as dimples. So that is the reason, skin lymphedema. And areola contains modified sebaceous gland that is are called glands of Montgomery, and these can enlarge in pregnancy and lactation. Right, those are called Montgomery's tubercles. You can see there are a lot of Montgomery's tubercle. Right. So lymphatic drainage of the female breast, most of the lymphatic drain into the axillary node. Right. So in breast cancer, the most common group of node enlargement is the axillary node. And some of the nodes can, the lymph can drain into internal mammary node. Right. Thorax, important considerations, you know, rib fractures, the common sites, usually the site of the fracture is the angle of the ribs, and least common fractured ribs are the first and the 12th rib, and plial chest is due to multiple rib fractures, because rib can fractures as multiple ribs or single ribs. So when there is a multiple rib fractures at two sides, the fractured segment act as a valve, or it creates paradoxical movement. That means that free segment moves in when you inspirate and it moves out when you expirate. That results in ineffective breathing. Right. So intercostal tube insertion principles I discussed. So important thing is you have to insert it in the safe triangle and above the particular ribs. Pneumothorax, hemothorax, and effects of coronary artery block. So that results ischemia to the heart and esophageal constriction, and their significance result dysphagia, clinical significance of bronchial tree and bronchopulmonary segments. Right. So those are the things that you have to know. I'm not going to explain all this. Right. In the abdominal wall, there are muscles, innervation and referred pain and rectus sheath. You have to know the surgical incision of the abdominal wall and know only what are the layers involved at different sites. No need, no need to know the name and their advantages, disadvantages. But if we ask what are the layers encountered when you make an incision at the midline until you enter the peritoneal cavity, or when you make a incision at the McBurney's point, or when you make incision over the rectus muscle, right? So what are the layers encountered at different levels? That's what we have to know. Right. Right. Inguinal hernia, I show you the picture of inguinal hernia and the femoral hernia also. So there are two types of inguinal hernia: indirect hernia protrude to the deep ring, and direct inguinal hernia protrude directly through the posterior wall. So this sort of hernia is the largest hernia I have seen. You cannot diagnose clinically whether it is a direct or indirect until you do the surgery. So at the surgery you can differentiate, because this is called Hessel's triangle demarcated by the conjoint tendon, then the inguinal ligament and the inferior epigastric artery, right? So within this triangle you get the direct inguinal hernia. So lateral to the inferior epigastric artery, or lateral to the triangle, you get the deep, through the deep inguinal ring, you get the indirect inguinal hernia. So direct inguinal hernia comes through this Hessel's triangle, medial to the inferior epigastric vessels. So by looking at the relationship to the inferior epigastric artery, you can diagnose whether it's a direct or indirect inguinal hernia. Right. Peritoneal cavity. In the male, the peritoneal cavity is a complete closed sac, but in female, it is the open sac. Right. So regarding the peritoneum, you have to know the lesser sac and greater sac. What is and peritoneal ligaments and what are mesentery and all these. And here you have to know the important area in the peritoneal cavity, the lesser sac and the greater sac, and communicate via the epiploic foramen. And epiploic foramen is bounded anteriorly by the structures in the freeboard of the lesser omentum, which contain, uh, you can see, hepatic duct and the portal vein and hepatic artery. You can see it clearly, and through that you go into the lesser sac. Right. So it's a site for internal hernia. Right. So right, the hepatic artery can be compressed between the thumb and index finger to arrest bleeding from the cystic artery. Right, inserting the index finger into the epiploic foramen and thumb over the freeboard of the lesser sac, lesser omentum, you can compress the that is the hepatic artery, that is called Pringle's maneuver. It's called Pringle's maneuver. And there are, that is the largest sac is the lesser sac. In addition to that, there are other recesses or small sacs in the peritoneal cavity. Out of these, there are few recesses around the duodenojejunal junction here. Those are called the paraduodenal fossae. Right. So there are four of them: retro and para, supra, and infraduodenal fossae. All the individual you don't see all the fossae. Right. So this is a retroduodenal fossa. Clearly you can see. Right. And around the cecum again you get the retrocecal recess like this. And behind the sigmoid colon, you see retrosigmoid recess, right? And the other important recesses are the subphrenic spaces between liver and the diaphragm. You can see this is the left subphrenic space, and this is right subphrenic space, divided into two by the falciform ligament, the attachment of the falciform ligament. And deep to the liver, you get subhepatic spaces. Out of these, the right subhepatic space is the largest one, and left subhepatic space, also known as the lesser sac. Right. Why these fossae and sacs or the recesses are important? These are the sites where you can get internal hernia as well as collection of abscesses or infections. Right. Okay, so this just to show you the direction of flow of fluid when a patient is supine on the bed, right? You can see, for example, if there is a ruptured appendix or any pelvic abscesses, it can track down into the Morrison's pouch or the right subhepatic space and to the right subphrenic space. An important thing is you can see the pus cannot pass along the left paracolic gutter into the left subdiaphragmatic space because of the presence of phrenicocholic ligament. These are the stomach bed structures. This is normal anatomy. You have to know what are the structures. Or those structures can involve with when there is a carcinoma of the stomach or perforation of the stomach. And these arterial supply to the stomach, you can see with good anastomotic arteries. So therefore, you can ligate one or two arteries, and stomach can survive with two arteries. So that is the anatomical principle that we use to take the stomach or mobilize the stomach to bypass the esophagus, right? Because the stomach has very good blood supply. Similarly, it has extensive lymphatic drainage. You can see it drains to the nodes in the porta hepatis, and in this direction is nodes in the splenic hilum, and also nodes in the pancreas, right? So therefore, the when there's a malignancy or carcinoma in the stomach, it can spread to all these nodes, and therefore stomach carcinoma difficult to cure. So small intestine, we have to know to differentiate the jejunum and ileum. So I'm not going to describe all this. So these two pictures you must be familiar with, maybe your spots. Right, the appendix, I told you the how to surface mark the appendix, and you have to know its various positions. And this the appendix is the intra-abdominal structure that most commonly inflame, and it is supplied by a single artery, appendicular artery, and in appendicitis this artery can get thrombosed and appendix can get necrosed, in contrast to the gallbladder, which is the second commonest structure to get inflamed within the abdominal cavity, and it has dual supply from the cystic artery and via the hepatic bed. So therefore, in polycystitis, the gallbladder is rarely gangrene, right? Because it has, even though the cystic artery is thrombosed, it has supply from the hepatic bed, right? The portal vein, you should know the anatomy of the portal vein and sites of its portosystemic anastomosis, the lower end of the esophagus and the rectum, and also in the anterior abdomen. These are the three most important sites. In addition to that, you get in the retroperitoneal space and the bare area of the liver, you get portosystemic anastomosis. So in portal hypertension, these sites become very important, because when there is a enlargement of these sites at the lower end of the esophagus, results esophageal varices and leads to hematemesis, and rectal varices lead to rectal bleeding. And remember, the enlargement of veins at the rectum does not cause hemorrhoids. Hemorrhoids are different entity. So it results what are called rectal varices. Then enlarged umbilical vein results a clinical signs which is called caput medusae. So this is varicose veins in the esophagus, or we call the esophageal varices. This is caput medusae. You can see enlarged veins around the umbilicus. Right. This is a superficial epigastric vein that you can see it's enlarged, and here you can see it faintly connect with the thoracoepigastric vein. It is not clear in this, right? Gallbladder. So you have to know the parts of the gallbladder and the blood supply I have told you, and this is the Callott's triangle, which is bounded by the inferior border of the liver, the hepatic duct, and the cystic duct, and within that you can see the hepatic artery. So to identify the hepatic artery, you should know the surface marking of Callott's triangle, which is important in, especially in laparoscopic surgeries. Right, so this I have mentioned, and this is the pancreas behind the stomach. So you can see, so any inflammation of the pancreas affect the structures in the stomach bed, right? So fluid collection in pancreatitis results enlargement of, or collection can enlarge within the lesser sac, and that is known as pseudocyst of the pancreas. And you can see the important relation here, the splenic artery. So in chronic pancreatitis, the splenic artery can involve and causes splenic artery aneurysm, and sometimes it can rupture and bleed. Right, and then you should know the anatomical relationship between common hepatic duct or the bile duct and the pancreatic duct. They both open together into the second part of the duodenum. Therefore, when there is any pathology of the head of the pancreas or in the common bile duct, it can affect by the pancreas or as well as the hepatobiliary system. For example, carcinoma of the head of the pancreas can obstruct the bile duct results jaundice. Similarly, gallbladder, the stones can pass to the common bile duct, can obstruct at the duodenal papilla, results blocking of the pancreatic duct and results acute pancreatitis like this. Right. So this intimate relationship you have to know. Right. Spleen, important relation you must know, because splenectomy is a common form of surgery, because the spleen is the most common solid organ to rupture in trauma in the abdomen, right? Therefore, emergency splenectomies are being done commonly in surgery. So these are the structures that can commonly damage tail of the pancreas, splenic fracture, right? And during ligation of, especially the tail of the pancreas, during ligation of the splenic artery, right? And that can lead to again pancreatitis, right? So okay, so this is the lienorenal ligament, and this is the phrenicocholic ligament, right? Lienorenal ligament, phrenicocholic ligament. You can see when the spleen is enlarged, it enlarged towards the right iliac fossa due to the presence of this phrenicocholic ligament. The spleen cannot enlarge downward like this, right? So you have to know the layers of the scrotum. So I am not going to name them, what are the layers, so you must know, because the things that we have to know when there is the scrotum, this is the this is the tunica vaginalis, right? So within this the fluid can get collect, and that results what is called hydrocele. So your question may be, what are the layers encountered when you do hydrocelectomy? That is making incision up to the height, up to the tunica vaginalis, right? So you should know what are the layers, or what are the layers encountered when you expose the testis. That is, what are the layers from skin up to the testis, tunica albuginea, right? So those things you should be able to tell, right? So you can find out these things from your textbooks. Varicocele, that is the dilated tortuous veins in the testis, right? In the papilliform plexus, that is most common in the left side. You should know the reason, because left testicle corresponds to loaded, is compressed by loaded sigmoid colon on the left side, and is obstructed by angulation at its entry into the renal vein, right? And the vein is put into spasm by adrenaline rich blood entering the renal vein from suprarenal vein, because the left testicular vein open into the renal vein, and the suprarenal vein also open into the left renal vein. So there are three reasons why left sided varicoceles are common, right? Okay, so testis origin from L1 to L3 level, and it descends down. So at the right side of the kidneys, so kidney and the testis share the same vein fibers. So sometimes your pain from the kidney referred to the scrotum, and conversely testicular pain may relate to the or refer to the loin area. Yes, so you have to know what is male-descended testes, undescended testes, their sites, right? And what are congenital hernia due to patent processus vaginalis, and inguinal hernia also results due to persistent processus vaginalis, right? So do you know extravasation of urine to the space between damage to the bulb urethra? So extravasation of urine occur into the superficial perineal space when there is damage to the bulb urethra. And why it is not occur in damage to the female urethra or sponge urethra? Because female urethra does not pass through the superficial perineal space, and sponge urethra is already within the penis, and it does not open into the superficial perineal space, and urine does not enter into the thigh because the the membranous fascia is attached to the fascia lata, so its space does not continue, but its space continue up to the umbilicus. So extravasation can go up to the umbilicus, and this diagram is a controversial part because some book says the urine can extravasate into the shaft of the the penis, and some books say the root of the penis, right? Is ideally it should be the root of the penis because the buck fascia is attached to the root of the penis, and this is the ruptured bulb urethra, and ruptured membranous urethra, the urethra above the membrane or membranous urethra between the prostatic membranous urethra junction can commonly occur in pelvic fractures that results extravasation of urine into the pelvic cavity, right? Retroperitoneal extravasation. And same thing can happen when the bladder is injured. But if the dome of the bladder injured, the urine passes into the peritoneal cavity. Right. So obstetric measurements, I am not going to explain these things, just to highlight that these are the things you should know, especially when you're coming for the Viva. This is a common Viva question in because you will get at least 1 or 2 gynecologists, they will ask this, right? And different shape, different size of pelvis, gynecological assessment, right? Obstetric measurements, difference between male and female pelvises, right? At least you should know these differences. This is a list from the Harold Ellis. You should know at least these things, right? So this thing definitely will ask if you encounter gynecologist as your Viva examiner. Right. In female, the perineum, the important gland is the Bartholin gland, which can enlarge and infect in some individual. What is then it is called Bartholin cyst. When it is infected, it is called Bartholin abscess. So this is the bulbary, the Bartholin gland within the superficial perineal space. No, that is the enlarged Bartholin cyst. That is called Bartholin gland cyst. Right. Then episiotomy, you should know what is episiotomy. That is a procedure to prevent damage to the perineal body during delivery. Right. So which position to cut? The posterior lateral on the right side. And what layers to cut? You should know skin, superficial fascia, fat, superficial transverse perineal muscle, and vaginal epithelium. And remember, perineal body is not cut because some book says the perineal body is cut. The aim of the procedure is to preserve the perineal body, so it is not cut. So this is the site of incision of episiotomy. Right. Hysterectoral fossa is the important area in the anal triangle of the perineum. So it posteriorly continues with the lesser sciatic foramen into the gluteal region, and anteriorly it continues with the opposite side. So these are the, so you have to know the boundaries. You should be able to explain all this. And pudendal nerve block, this is a nerve that supply your perineal structures, and it can be blocked by 2 methods, transvaginal and transperineal method. In both cases, the nerve is guided by the ischial spine. So ischial spine, you feel, keeping the finger within the vagina and insert the needle through the vagina or through the skin near your fingertip and infiltrate the anesthetic solution. Right. Pouch of Douglas is the most dependent part of the pelvis cavity in female in seated position, right? And importantly, it is related to the posterior vaginal fornix. So therefore, any collection of pus within this pouch of Douglas can drain via the posterior fornix through the vagina without cutting into the abdomen. Similarly, uh, when do instrumentate for some procedures into the through the vagina, the posterior fornix can get damaged and the infection can enter into the perineal or the peritoneal cavity, right? Peritoneal cavity. That can happen especially in illegal abortions resulting in peritonitis. Right. So urinary bladder, I told you that you have to know the relationship to the peritoneum. So when it's injured the dome of the bladder, urine extravasates into the pelvic cavity. When the bladder ruptured in the inferior and lateral surfaces, urine extravasates into the retroperitoneal or extraperitoneal space. Is a suprapubic puncture, that is the inserting of a cannula or a catheter into the bladder through the anterior abdominal wall. So here you should know you need not to know the procedure, but what you have to know is what are the layers that you puncture when you insert this tube into the bladder through the midline just above your symphysis pubis, right? So there you have to know the layers. And this is urethral catheterization. The female is very easy because short and almost straight, even though it's slightly shaped, but it's straight urethra. But it's difficult in male because it's longer and it's shaped. You have to negotiate various points. So those things you have to know. Right. Importantly, there are a few anatomical considerations when you are inserting a catheter into male urethra. One is the narrowest point is at the tip of the penis, and there is the uh, navicular fossa is here, and there are recesses towards the roof of the navicular fossa. So you have to take care not to insert your tip of the catheter into them, right? And then the shaft of the urethra, the penis, the spongy urethra, it encounter angle here. So in this angle, we have to negotiate by holding the penis straight, right? From there, it enter into the bulbar urethra. So this is the penile urethra and the bulbar urethra junction. The next resistant encounter at the membranous urethra. You can see there is a 90-degree angle, as well as this is the most narrow. This is the narrow and least distensible part of the urethra, membranous urethra. Then if you negotiate that, then the catheter enter into the most dilatable and large part of the urethra, the prostatic urethra, then enter into the bladder. So in this case, you have to consider the length of the urethra as well, about 25 centimeters. Right. Prostate gland, regarding prostate gland, benign prostate hyperplasia or enlargement and CA prostate, and basis of spread of prostatic carcinoma to the brain and vertebrae via the varus plexus of veins. You have to know. Right. And supports of the uterus, different position of the uterus, urethra and uterine artery relations, ectopic pregnancy. These are the important things that you have to know about the uterus. Anal canal, differences of mucosa and related diseases, and anal fissure, fistula, these things not important, but you have to know the anatomical basis for hemorrhoids. Right. Hemorrhoids are enlarged and distended anal cushions. And remember, these are not varicose veins of the anal canal or the rectum. Right. So these are the hemorrhoids, internal hemorrhoids. Right. These are prolapse, enlarged internal anal cushions. And this is external hemorrhoid. This is just ruptured veins, perianal veins. And per rectal examination, you must know what are the things that you can feel. In both sexes, in normally, you can feel coccyx, sacrum, menococcygeal body, ischiorectal fossa, and ischial spine. Then male, you can feel retrovesical pouch, bladder, seminal vesicle, vas, and prostate. Then female, retrouterine pouch, and cervix and vagina. So in addition to that, you can feel a lot of abnormal things. Right, this is per rectal examination. Right. And so in pelvic fractures, important thing that you have to know is what are the soft tissues that can be damaged. Right. And them can damage urethra, bladder, and arteries, major arteries, external and internal iliac arteries, and veins, especially the veins can be damaged and cause retroperitoneal bleeding, which can extend up to the kidneys, level of the kidneys, right? Because you know, uh, along the course of ureter, the posterior peritoneum is loosely attached, right? And damage to the rectum is very rare in pelvic fractures. Right. So nerve injuries can occur in pelvic fractures and can involve sciatic nerve injury when there is a fracture, greater sciatic notch, or acetabular fracture can cause, especially during posterior dislocation of the hip. Right. And the peroneal part involved commonly because that is the anterior part of the nerve. Right. So that is the part that touches the bone. Right. So in the lower limb, there are bursae that you have to know. The ischial tuberosity, there is a bursae that can enlarge in people who sit for a longer period. For example, weavers. So we call it weaver's bottom. And this thing I have explained you what is prepatellar bursitis, the housemaid knee, and this is the clergyman's knee. You can see this is an enlarged infrapatellar bursa. Right, and this is the called bunion, which is the interstitial bursa over the head of the first metatarsal. Right, then you have to know the compartments of the leg and the compartment syndrome. So I am not going to explain this thing. Right, so this is the release of compartment, making incision in the deep fascia, what is called decompression of the compartment, the fasciotomy. Right. Then come to the dislocation of and fractures of the femur. The important thing that we have to know, the avascular necrosis of the head of the femur can lead in dislocation of the hip as well as fracture neck of femur, because the neck or the head of the femur is supplied by retinacular vessels. That is the main contribution. So therefore, intracapsular fracture of the femur, neck of the femur can lead to avascular necrosis due to cut off of this blood supply from the retinacular vessels. Right, and this is the supracondyle fracture of the femur. You can see that can injure the popliteal artery, results ischemia to the leg and the foot. Right, so this displacement of the distal part of the femur is due to the action of gastrocnemius, which is attached to the two condyles of the femur. And there is a natural tendency of dislocation of the patella towards the lateral side. So that is prevented by few factors. One is the more prominent lateral epicondyle. The other one is the action of the vastus medialis. You can see vastus medialis muscles are attached to the medial side of the patella. Vastus lateralis is attached only to the superior pole, right? So because of this, the patella pulls toward the medial side, so that these two factors prevent the natural tendency of displacement of patella to the lateral side. Other injuries at the knee is the cruciate ligament injury, anterior cruciate and posterior cruciate ligament can injured. You know, the anterior cruciate ligament injury results anterior mobility, increase anterior mobility or displacement of the tibia. So you can test what is called Latchman test. Try to mobilize the tibia over the femur anteriorly. So if it is mobility is more, that is anterior cruciate ligament injury. The posterior cruciate ligament injury results posterior displacement of the tibia over the femur. So you try to mobilize the tibia over the femur posteriorly. So if it is posteriorly mobile, so it is the that is then you can diagnose posterior cruciate ligament injury. Right. Then comes the scalp. You have to know all the layers of the scalp. So it is the site of the sebaceous cyst, the most common site, and you know what is danger zone. That is the areolar tissue. Then succedaneum is the any fluid collection within this danger zone, because it is then spread all over the scalp. In contrast to the Keppel hematoma is the fluid collection or blood or fluid collection within the or deep to the periosteum. Right. So that results the collection limited to one bone. Right. That is called Keppel hematoma. And you should know the anatomical basis for why any wounds profuse to bleed, because the scalp has rich blood supply with rich anastomosis, and it is supplied by both external and internal carotid arteries. Right. So because it had good blood supply, it heals fast. Right. And emissary veins connect your intracranial or intracerebral veins, and that results spread of infection from scalp infection into the brain and to the meninges. Right. And in the head and neck region, the other important structure is the thyroid. So enlargement of thyroid is known as goiter. And when considering the thyroid surgeries, you have to talk about recurrent laryngeal and the superior laryngeal nerve, the external branch. I discussed that earlier. The thyroglossal cyst is a congenital abnormality where the persistent duct, part of the duct can enlarge. And ectopic inferior parathyroid gland, the anatomical basis you have to know, because the inferior parathyroid develop with the thymus from the third pharyngeal pouch. So then along with the thymus, the inferior parathyroid gland can descend right into various positions. So ectopic parathyroid common in inferior gland. Right. So regarding parotid gland, swelling of the parotid and inflammation is very painful due to the firm attachment of the parotid, the capsule of the parotid gland. Then Fraze syndrome, you should know, that is gustatory sweating. In the other words, so that is due to cross communication of sympathetic and parasympathetic nerve fibers after parotid surgeries. And bleeding is a common complication during parotidectomy from retromandibular vein and external carotid artery. So you should know what is xylogram. That is a radiological procedure to demonstrate the parotid duct. When it's called parotid, it's come to parotid xylogram. When it is being done sorry, I don't know what happened. Yes, okay, right. When it is being done to the submandibular gland, we call it submandibular xylogram. Right. So malignant tumors of the parotid can be diagnosed by facial nerve palsy, because benign one does not cause palsy, because malignant tumors infiltrate the facial nerve and result facial nerve palsy, right? And parotid region lumps may be parotid gland or even parotid lymph nodes, because there are lymph nodes within the parotid capsule. Submandibular gland, on the other aspect, there is again the second largest the salivary gland, and it has deep and superficial lobe. Therefore, you can feel it bimanually when it is enlarged. So, by that you can differentiate it from enlarged submandibular lymph node, which is not palpable bimanually. And there are important relations to the gland, the lingual nerve and the hypoglossal nerve. The other important nervous structure is the submandibular ganglion. All these three structures are in danger during submandibular gland excision. Right? In addition to that, the marginal mandibular nerve of the facial nerve, even though it is not related to the submandibular gland, it can encounter surgical incision for submandibular gland excision. Therefore, you can remember there are 4 nervous structures can be damaged during submandibular gland excision. That is submandibular ganglion, lingual nerve, hypoglossal nerve, and the marginal mandibular branch of the facial nerve. Right. So this you have to know. You might have to show this in Viva. Sometimes they will ask to show the how the lingual nerve crossed by the how the lingual nerve cross the submandibular duct. So it crossed laterally and again medially. Right. Okay. And calculi is commoner in submandibular gland than the parotid gland due to reason thick secretion and drains against gravity. It drains against the gravity. Right. And considering the venous system of the intracranial or the cranial cavity, you should know the venous sinuses. Out of these, superior sagittal sinus and sigmoid sinus are considered clinically important, because most of the clinical problems occur in these 2 sinuses. And importantly, the superior sagittal sinus, you can see the arachnoid villi are there, and these are the sites where cerebrospinal fluid enter into the circulation. So any blocking of the superior sagittal sinus results blocking of these arachnoid villi as well, leading to increase amount of cerebrospinal fluid within the cranial cavity, resulting what is called hydrocephalus. It is called hydrocephalus. So that can result secondary to thrombosis of the sinus, in meningitis and all this. And sometimes this superior sagittal sinus can get thrombosed secondary to otitis media. So then it is called otitic hydrocephalus. The cavernous sinus become important because it has important communication, right? The cavernous sinus communicate with emissary veins, with the veins of the face, and intratemporal fossa, as well as cerebral veins. Right. In addition to that, it has important relation. Within that, you see the abducens nerve and the carotid artery, and in the wall you get 4 nerves. So all these nerves can get affected when the cavernous sinus is thrombosed, right? So effects on these nerves I have explained when we discuss the cranial nerve injuries, right? And how this can get thrombosed due to spread of infection from the face or from the scalp, right? And the face, especially, you have to know what is the danger area, which involves the central part of your upper lip and the lower part of the nose. That is the part that directly drain into the cavernous sinus via the deep facial vein. Right. Okay. So these are the communicate. These are theory behind. So we have to know what are the theory behind this law. Right. Then skull. You have to know the skull fractures, and you should be able to tell the anatomical basis of localizing of fracture different cranial fossa. So anterior cranial fossa fracture can result bleeding into the nose or mouth due to fracture of the cribriform plate, which is the roof of your nose. And CSF also can leak through the nose, and that implies the coexisting tearing of the meninges. And subconjunctival hemorrhage can result because you know the roof of your eyes is the flow of the anterior cranial fossa. So when the flow is fractured, the blood can enter into the orbital cavity. So subarachnoid space may communicate with the exterior via the nasal cavity with consequent risk of meningitis. So when if there is a CSF leakage, the anterior cranial fossa fracture can lead to meningitis. And when the cribriform plate fractured, that can result olfactory nerve involvement resulting anosmia. And when the optic foramen is involved, there can be optic atrophy and leads to blindness. And black eye is not necessarily indicative of an anterior cranial fossa fracture, that you must know. That is due to bleeding under the scalp. Right, this is black eye. Here you can see injuries here in the forehead, the track down of blood deep to the within the loose areolar tissue can track down here deep to the aponeurosis, right, and can track down around the eye. This is called black eye. This is not indicative of anterior cranial fossa fracture. So on the other hand, the fracture middle cranial fossa can involve the tympanic cavity, because you know the middle ear within the petrous temporal bone, and the sphenoid bone is the roof of your pharynx. So if the bone is fractured, the bleeding into mouth can occur, and bleeding of CSF leak from the ear due to fracture of the middle and internal auditory meatus, that the facial and auditory nerve can get injured. Right. So ear bleeding may be produced by direct injury to the ear also, or by ruptured eardrum. Right. So abducen nerve may be damaged with diplopia and paralysis of lateral rectus muscle in middle cranial fossa fracture. Posterior cranial fossa is rarely fractured because it has a thick bone and is accompanied by cranial nerve involvement. And these fractures are suggested clinically by bruising over the mastoid process, which is called battle sign. Right there, you can see bruising at the over the mastoid process. Right. Then the intracranial bleeding can occur in trauma as well as rupture of aneurysms. So you have to know there are mainly 4 types of hemorrhages: extradural, subdural, subarachnoid, and intracerebral. What you have to know is what are the type of blood vessel involved in different categories of bleeding. So this is the extradural hemorrhages, that is external to the dura. So the damaged vessels are the meningeal vessels, either meningeal artery or meningeal vein. The CT scan to show the extradural hemorrhage, and this is surgery. You can see the blood clot, right? The skull is removed to remove the blood clot. Right. So this is subarachnoid or subdural intracranial bleeding. Right. So subdural means between the dura and the arachnoid. This is the most common type of hemorrhage in head injury, and this is due to injury to superficial cerebral veins. These veins enter into the superior sagittal sinus, and when they pass, they have to pass to the subdural space. So subdural space is a potential space, right? So this subdural hemorrhages can occur even without fracture of the skull. This is due to vigorous shaking of the brain. The delicate vein can get ruptured. So usually the subdural hemorrhages, extradural hemorrhages accompanied with like this cranial skull fractures, but subdural hemorrhages not necessarily accompanied with skull fractures, right? Then you get the subarachnoid hemorrhages where bleeding within the subarachnoid space. This is due to injury to cerebral arteries. This is not due to trauma, but this can occur due to rupture of aneurysmal blood vessel within the circle of Willis. Right, then this is intracerebral bleeding, may be non-traumatic or may be traumatic, right? So here you can see this is due to damage to capillaries of cerebral capillaries, intracerebral within the brain matter. So that leads to various symptoms and signs depending on which part of the brain is involved, right? Maybe leads to paraplegia, right? Yes, this is the battle sign, right? Posterior cranial fossa fracture. Okay, I think we have come to the end of the lecture. Yes. Okay. So any questions if you have?
Excuse me, sir.
Yeah.
Sir, if you don't mind, can we have this presentation?
Yeah. There's a question. So in ectopic tubal pregnancy, can we say the hemorrhage and severe bleeding can be also due to rupture of uterine venous plexus vein in addition to the relevant artery? Yes. So in ectopic pregnancy, tubal pregnancy, the bleeding can be uh, due to injury. The bleeding is from ovarian arteries, uterine arteries, and also relevant veins, not only arterial, right? But mainly from arterial blood accompanied by venous bleeding as well. You can say that, but mainly remember it's arterial bleeding. That's why it's, there will be severe bleed. Hmm? Any more questions? Okay. Any more questions? Right. So if there's no more questions, I can stop. Right. Okay then. Thank you.
Thank you.
Thank you, sir.
Thank you,
sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Recording